to our cardiology department program, interactive session with our Neyyar Medicity doctors and especially doctors practicing near Neyyar Medicity, our friends. നമ്മൾ ഈ ഐഡിയ കൺസീവ് ചെയ്തിരിക്കുന്നത് തന്നെ ഒരു അക്കാഡമിക് ഇൻട്രാക്റ്റീവ് പ്രോഗ്രാമാണ്. കാർഡിയോളജി വേൾഡ് കാർഡിയോളജി ഡേ ആണ് 29th വരുന്നത്. ഈ കമ്മിങ് 29th ഈസ് വേൾഡ് കാർഡിയോളജി ഡേ. അത് ഇൻ കണക്ഷൻ വിത്ത് ദാറ്റ് വേൾഡ് കാർഡിയോളജി ഡേ നമ്മളൊരു ഇൻട്രാക്റ്റീവ് പ്രോഗ്രാം ഫ്രം അവർ കാർഡിയോളജി ഡിപ്പാർട്ട്മെൻറ്റ് എന്ന രീതിയിലാണ് നമ്മൾ കൺസീവ് ചെയ്തിരിക്കുന്നത്. അപ്പോൾ നമ്മളുടെ സമീപത്തുള്ള പ്രമുഖരായിട്ടുള്ള ഡോക്ടേഴ്സ് പലരും എത്തിക്കഴിഞ്ഞു. കുറച്ച് പേര് ഇനിയും വരാനുണ്ട്. എല്ലാവർക്കും നമുക്കെല്ലാം അറിയാം, വൈകുന്നേരത്തെ ക്ലിനിക്കിലെ തിരക്കൊക്കെ കഴിഞ്ഞ് എത്തേണ്ടതാണ്. അപ്പോൾ നമ്മൾക്ക് ഏറ്റവും പ്രധാനപ്പെട്ട ഈ ഒരു ഇൻട്രാക്ഷൻ്റെ പ്രത്യേകത എന്ന് പറയുന്നത്, കാർഡിയോളജി നമ്മൾ എക്കാലത്തും നമ്മൾ പഠിക്കുന്ന കാർഡിയോളജി ECG റീഡിങ്ങും ഒക്കെ എല്ലാവർക്കും അറിയാവുന്നതാണെങ്കിൽ പോലും ഇന്നത്തെ ഒരു കാലഘട്ടത്തിൽ നമ്മൾക്കിന്ന് മെഡിക്കോ ലീഗൽ ആൻഡ് പബ്ലിക് വയലൻസിൻ്റെ ഒരു കാലഘട്ടത്തിൽ നമ്മൾ പ്രത്യേകിച്ച് നമ്മുടെ ഹോസ്പിറ്റലാണെങ്കിലും പെരിഫറിയിൽ നമ്മൾ വർക്ക് ചെയ്യുമ്പോഴും മറ്റ് ഹോസ്പിറ്റലുകളിൽ വർക്ക് ചെയ്യുമ്പോഴുമൊക്കെ ഒരു കാർഡിയോളജി എമർജൻസി എങ്ങനെ നമ്മൾക്ക് പിക്ക് ചെയ്യാം, കണ്ടുപിടിക്കാമെന്നും അത് പ്രോപ്പറായിട്ട് എങ്ങനെ റെഫർ ചെയ്യാം അല്ലെങ്കിൽ അതിനൊരു കൺസൾട്ടേഷൻ എടുക്കാം എന്നും ഉള്ളതാണ്, ഒരു ഒപ്പീനിയൻ എടുക്കാം എന്നുള്ളതുമാണ് നമ്മൾ പ്രധാനമായിട്ട് ഉദ്ദേശിച്ചിട്ടുള്ളത്. സാർ ഇവിടെ ഇരിപ്പുണ്ട്, സ്കീമിൻ്റെ വളരെ വക്താവാണൊക്കെയാണ്, IMA വളരെ നേതാവാണ്. PP സ്കീം, പ്രൊഫഷണൽ പ്രൊട്ടക്ഷൻ സ്കീം നമ്മളെല്ലാവരും എടുത്തിട്ടുണ്ട്, മസ്റ്റാണ്. അതുപോലെ തന്നെ നമുക്കൊരു പബ്ലിക് പ്രൊട്ടക്ഷൻ സ്കീമും കൂടെ വേണ്ട ഒരു കാലഘട്ടത്തിലാണ് നമ്മൾ നിൽക്കുന്നത്. സ്വന്തമായി ബൗൺസേഴ്സിനെയോ ആശുപത്രികൾ ബൗൺസേഴ്സിനെയോ ഒക്കെ വെച്ച് അത് മാനേജ് ചെയ്യേണ്ട ഒരു കാലഘട്ടത്തിൽ ഇങ്ങനെ ഒരു പെട്ടെന്ന് നമുക്കൊരു ECG കണ്ടാൽ അറിയാം, നമുക്ക് ഹൈപ്പർ അക്യൂട്ട് MA കണ്ടാൽ എല്ലാവർക്കും അറിയാം, നമ്മളെല്ലാവരും അതിൽ ട്രെയിൻഡാണ്. പക്ഷേ ഒരു ഹൈപ്പർ ടെൻഷൻ ഒരു പരിധിയിൽ കൂടിക്കഴിഞ്ഞാൽ നമ്മൾ എന്ത് ചെയ്യണം, എങ്ങനെ ചെയ്യണം, ഒരു അരിത്മിയ നമ്മൾ എങ്ങനെ മാനേജ് ചെയ്യണം, പിന്നെ ഒരു അന്യൂറിസം, പെട്ടെന്നൊരു അന്യൂറിസം, ഒരു പ്രത്യേകിച്ച് ഒരു 3 ട്രിപ്പിൾ വെസൽ ഡിസീസ്, ഒരു ആൻജിയോപ്ലാസ്റ്റി, ഒരു ആൻജിയോഗ്രാം, കൊറോണറി ബൈപ്പാസ് ഒക്കെ ചെയ്ത പേഷ്യൻ്റ് ആണെന്നുണ്ടെങ്കിൽ വലിയ പ്രശ്നമില്ല, അവർക്ക് അറിയാം അതിൻ്റെ റിസ്ക്കുകൾ. പ്രത്യേകിച്ച് യങ്ങർ ഏജ് ഗ്രൂപ്പുകളിലും ഇഷ്യൂസൊക്കെ വരുമ്പോൾ നമ്മൾ എങ്ങനെ മാനേജ് ചെയ്യണം എന്നുള്ളത് നമുക്കൊരു പ്രശ്നങ്ങളാണ്. നമ്മളുടെ സൈഡ് നമ്മൾ സേഫ് ആക്കിക്കൊണ്ട് ഒരു കൺസൾട്ടേഷൻ എടുക്കുക എന്നുള്ളതാണ് പ്രധാനമായിട്ടും നമ്മൾ ഉദ്ദേശിക്കുന്നത്. അതായത് വളരെ വ്യക്തമായിട്ട് ഞാൻ അതിനെക്കുറിച്ച് പറഞ്ഞാൽ, നെയ്യാർ മെഡിസിറ്റിയിലോട്ട് എല്ലാ നമ്മളുടെ പേഷ്യൻസിനെ എല്ലാം റെഫർ ചെയ്ത് നെയ്യാർ മെഡിസിറ്റിയിലെ കാർഡിയോളജി ടീം അവരെല്ലാം അബ്സോർവ് ചെയ്യുന്നു എന്നൊരു കൺസെപ്റ്റ് ഞങ്ങൾക്ക് മാനേജ്മെൻറ്റിനും ഇല്ല, കാർഡിയോളജി ടീമിന് എൻറ്റയർ ടീമിനും ഇല്ല. നമ്മളൊരു സമീപത്ത് പ്രാക്ടീസ് ചെയ്യുന്ന ഒരുവിധം ഫെസിലിറ്റി ഉള്ള ഒരു ഹോസ്പിറ്റൽ എന്ന നിലയ്ക്ക് അതിലൊരു കൺസൾട്ടേഷൻ എടുക്കുക, തിരിച്ച് ഏറ്റവും ആവശ്യമായ നമ്മളുടെ കട്ടാക്കട ഭാഗത്തും പരിസരത്തും എല്ലാം വളരെ മനോഹരമായിട്ട് നമ്മൾ ഒരുപാട് ഡോക്ടേഴ്സ്, ഫാമിലി ഫിസീഷ്യൻ എന്ന രീതിയിൽ നല്ല ഭംഗിയായിട്ട് നടന്നു പോകുന്നുണ്ട്. അത് അതേപടി നിലനിർത്തിക്കൊണ്ട് എമർജൻസി വരുന്ന സിറ്റുവേഷനിൽ ഒരു ഒപ്പീനിയൻ എടുക്കുകയും എന്തെങ്കിലും ഒരു ഇൻ്റർവെൻഷൻ വേണമെന്നുണ്ടെങ്കിൽ അതിലേക്ക് നയിക്കുന്ന തരത്തിലൊരു ഒപ്പീനിയൻ എടുക്കാൻ വേണ്ടിയുള്ള ഒരു ഒന്ന് സെൻസിറ്റൈസ് ചെയ്യുകയും ഒന്ന് അപ്ഡേറ്റ് ചെയ്യുകയും മാത്രമാണ് നമ്മളിതുകൊണ്ട് ഉദ്ദേശിക്കുന്നത്. ഇന്നത്തെ ഞാൻ അധികം സമയം എടുക്കുന്നില്ല, ടോപ്പിക്കിലേക്ക് കടക്കാം. ആദ്യമായിട്ട് എല്ലാ സുഹൃത്തുക്കളെയും, നമ്മുടെ മറ്റ് ഹോസ്പിറ്റലുകളിലും ക്ലിനിക്കുകളിലും ഒക്കെ വർക്ക് ചെയ്യുന്ന സുഹൃത്തുക്കളും ഡോക്ടർ സുഹൃത്തുക്കളും നമ്മുടെ ഹോസ്പിറ്റലിലെ എല്ലാ ഡോക്ടേഴ്സും മറ്റ് സ്റ്റാഫും നമ്മുടെ MD പ്രേം കിരണും ഇവിടെ ഉണ്ട്. എല്ലാവർക്കും ഈ പ്രോഗ്രാമിലേക്ക് സ്വാഗതം. നമ്മളുടെ കാർഡിയോളജി ഡിപ്പാർട്ട്മെൻറ്റിലെ മെമ്പേഴ്സിനെ ഞാനൊന്ന് പരിചയപ്പെടുത്താം. പ്രധാനമായിട്ടും ഇന്നിപ്പോൾ നമ്മളുമായിട്ട് സംവദിക്കുന്നത് നമ്മുടെ കാർഡിയോളജി സീനിയർ കൺസൾട്ടൻ്റ് ഇൻ്റർവെൻഷണൽ കാർഡിയോളജിസ്റ്റ് ഡോക്ടർ ഹരിഹര ശർമ്മ. അദ്ദേഹം കോമൺ ക്ലിനിക്കൽ സിറ്റുവേഷൻസ് ഇൻ കാർഡിയോളജി ആൻഡ് ഹൗ വി ഡീൽ ഇറ്റ് എന്ന വിഷയത്തെക്കുറിച്ചൊരു 15 മിനിറ്റ് സംസാരിക്കും. അത് കഴിഞ്ഞിട്ട് നിഷാന്ത് ഒരു കൺസൾട്ടൻറ്റ്, ഹരി കഴിഞ്ഞ് നിഷാന്ത് സാഗർ കൺസൾട്ടൻറ്റ് ഇൻ്റർവെൻഷണൽ കാർഡിയോളജിസ്റ്റ്, ഹൈപ്പർ ടെൻഷൻ ആൻഡ് വെൻ ടു റെഫർ ആൻഡ് വാട്ട് ഈസ് ന്യൂ ഗൈഡ് ലൈൻസ് എന്നുള്ള വിഷയത്തെക്കുറിച്ച് സംസാരിക്കും. ഹരിയെ നമുക്കെല്ലാവർക്കും അറിയാം, വളരെ ഇവിടുത്തെ ഒരു ലീഡിങ് സീനിയറായിട്ടുള്ള ഒരു പല ഹോസ്പിറ്റലിലും വർക്ക് ചെയ്യുന്നു. ഇപ്പോൾ നെയ്യാറിൻ്റെ ഞങ്ങളുടെ ഒരു നെടും തൂണാണ് കാർഡിയോളജി ഡിപ്പാർട്ട്മെൻറ്റിൻ്റെ. അതുപോലെ തന്നെ നിഷാന്ത് വളരെ അക്കാഡമിക്കലി വളരെ എഫിഷ്യൻ്റ് ആയിട്ടുള്ളതും വളരെ പ്രത്യേകം എൻ്റെ അടുത്ത് പറഞ്ഞു, അത് പറയരുതെന്ന് പറഞ്ഞു, പക്ഷേ എന്നാലും ഞാൻ പറഞ്ഞു പോകുന്നല്ലോ. ട്രിവാൻഡ്രത്തുനിന്ന് DM കഴിഞ്ഞു, DM കാർഡിയോളജിയിലെ ഗോൾഡ് മെഡലിസ്റ്റാണ്. അതുപോലെ തന്നെ നമ്മളുടെ വിജിത്ത് പിള്ളെ. വിജിത്ത് സംസാരിക്കുന്നത് കാർഡിയാക് ഇവാലുവേഷൻ ഇൻ സർജിക്കൽ പേഷ്യൻസ് പ്രീ ആൻഡ് പോസ്റ്റ് സർജറി. വിജിത്തും DM കോട്ടയം മെഡിക്കൽ കോളേജിൽ നിന്ന് കഴിഞ്ഞു. ഒരു മോർ ദാൻ 5 years ഇൻ ഇൻ്റർവെൻഷണൽ കാർഡിയോളജിയിൽ എക്സ്പീരിയൻസ് ഉള്ളതാണ്. ഇവർ 3 പേരും ആക്റ്റീവായിട്ട് പ്രൈമറി ആൻജിയോപ്ലാസ്റ്റി ഉൾപ്പെടെ എല്ലാം ചെയ്യുന്നതാണ്. അതിൻ്റെ ഫർദർ ഡീറ്റെയിൽസ് നമ്മുടെ സ്കോപ്പ് ഓഫ് ഹോസ്പിറ്റലിൽ ചെയ്യുന്ന ഫെസിലിറ്റിയെക്കുറിച്ച് ഹരി സംസാരിക്കും. എന്നാലും നമ്മൾക്കറിയാവുന്ന ഏറ്റവും പ്രധാനപ്പെട്ട MI ആൻജിയോഗ്രാമ്, ആൻജിയോപ്ലാസ്റ്റി, അതുപോലെ തന്നെ നമ്മുടെ പെരിഫറൽ ഒക്ലൂസീവ് വാസ്കുലർ ഡിസീസുകളൊക്കെ ഇപ്പോൾ വളരെ കോമൺ ആണ്. അതിന് വേണ്ടിയിട്ടുള്ള സ്റ്റെൻഡിങ് ഫെസിലിറ്റികളും ഒക്കെ നമ്മൾ ചെയ്യുന്നുണ്ട്. ICD, ഇൻറ്റേർണൽ ഡീഫിബ്രിലേറ്റർ, പേസ് മേക്കർ, പേസിങ് ഉൾപ്പെടെ എല്ലാവിധ ഇൻ്റർവെൻഷനായിട്ടുള്ള കാർഡിയോളജി ആക്ടിവിറ്റികളും നമ്മുടെ ഹോസ്പിറ്റലിൽ നടക്കുന്നുണ്ട്. ഒരൊറ്റ ഇൻസിഡൻ്റ് കൂടെ പറഞ്ഞ് ഞാൻ സമയം എടുക്കുന്നില്ല, വിഷയത്തിലേക്ക് കടക്കുകയാണ്. ഇത് കഴിഞ്ഞതിന് ശേഷം ഏറ്റവും പ്രധാനം, നമ്മൾ വൈകി എങ്കിൽ പോലും നമുക്കൊരു ഇൻറ്ററാക്റ്റീവ് സെഷനാണ് നമ്മൾ ഇതിനകത്ത് ഹൈലൈറ്റ് ആയിട്ട് നമ്മൾ കാണുന്നത്. കാരണം നിങ്ങളുടെ ഓരോരുത്തരുടെയും ഒരു ഇമ്പോർട്ടൻ്റ് ആയിട്ടുള്ള സംശയങ്ങൾ നമുക്ക് ഒരു ചർച്ചയിൽ കൂടി പരിഹരിച്ച് മുന്നോട്ട് പോകാമെന്നുള്ളതാണ് നമ്മളുടെ കൺസെപ്റ്റ്. അതിൽ ഹരിയെ ഞാൻ ഇതിലോട്ട് ഇൻവൈറ്റ് ചെയ്യുകയാണ് സംസാരിച്ച് തുടങ്ങുന്നതിനായിട്ട്. ഫസ്റ്റ് ടോക്ക് ഞാൻ പറഞ്ഞു നിർത്തി ഹരിക്ക് ഹാൻഡ് ഓവർ ചെയ്യുന്നതിന് ഒരു സംഭവം കൂടെ പറഞ്ഞിട്ട് ആ ഒരു കോർഡിനേറ്റർ നമ്മളുടെ ഹോസ്പിറ്റലിലെ ഒരു ആക്ടിവിറ്റിയെക്കുറിച്ച് ഒന്ന് പറഞ്ഞു മാത്രം നിർത്താം. ഏതാണ്ട് ഒരു 1000-ന് പുറത്ത്, ഇപ്പോൾ നമ്മൾ തുടങ്ങിയിട്ടൊരു 3 കൊല്ലം കഴിയുന്നേ ഉള്ളൂ, 1000-ന് പുറത്ത് തന്നെ ആക്ടിവിറ്റീസ്, കാത്ത് ലാബ് ആക്ടിവിറ്റീസ് നമ്മൾ കഴിഞ്ഞു. ഒരു മാസം തന്നെ മിനിമം ഒരു 30-40 അടുത്ത് കാത്ത് ലാബ്, പ്രൈമറി ആൻജിയോഗ്രാം ഉൾപ്പെടെ എല്ലാം നടക്കുന്നുണ്ട്. വളരെ ആക്റ്റീവായിട്ടൊരു സെൻ്ററാണ്. പ്രൈമറി ആൻജിയോപ്ലാസ്റ്റിയാണ് ഏറ്റവും പ്രധാനപ്പെട്ടത്. നമുക്ക് ഇമ്മീഡിയറ്റ് ആയിട്ടൊരു ഹൈ MI വന്നു, എനി ടൈം 24 hour വർക്ക് ചെയ്യുന്ന ഒരു സർവീസുമുണ്ട്. ഒരു ഉദാഹരണം മാത്രം പറയുന്നത്, നമുക്കൊരു നഗരത്തിലെ ഒരു പ്രമുഖ ഓർത്തോപെഡിക് സെൻ്ററായിട്ട് ഹോസ്പിറ്റലിൽ ഒരു 70 വയസ്സുള്ള ട്രിവാൻഡ്രത്തു നിന്ന് ഒരു ഓൾഡ് മാൻ, അദ്ദേഹത്തിന് ഒരു കംപ്ലീറ്റ് ഹാർട്ട് ബ്ലോക്കാണ്, ഒരു ഹിപ്പ് ഫ്രാക്ചറുണ്ട്, ഒന്ന് ഫിക്സ് ചെയ്യണം. അവിടെ ഇമ്മീഡിയറ്റ് ആയിട്ടൊരു പേസ് ചെയ്യാൻ ബുദ്ധിമുട്ടുണ്ട്. എങ്ങനെയാണെന്ന് വിളിച്ച് ചോദിച്ചു. ഉടനെ അന്ന് ഡോക്ടർ സജീവുള്ള സമയത്താണ്. അപ്പോൾ അദ്ദേഹം വിളിച്ചു, ഇങ്ങോട്ട് കൊണ്ടുവരാൻ പറഞ്ഞു. ഞങ്ങൾ ഇവിടെ കൊണ്ടുവന്നു. 12:30 ആയപ്പോൾ പേഷ്യൻ്റ് നമ്മുടെ ഹോസ്പിറ്റലിലെത്തി. ഹരിയെ ഞാൻ വിളിച്ചു പറഞ്ഞപ്പോൾ ഹരി പറഞ്ഞു, എന്ത് ഇമ്മീഡിയറ്റ് ആയിട്ട് ഞാൻ IV പേസ് ചെയ്ത് തരാം, സാറിന് ചെയ്യാൻ പറ്റുമെന്നുണ്ടെങ്കിൽ ചെയ്യാവുന്നതാണ്. 12:30 നമ്മൾ പേഷ്യൻറ്റിനെ കൊണ്ടുവന്നു. 2:30 ആയപ്പോൾ പേഷ്യൻ്റ് ഈസ് ഇൻ പോസ്റ്റ് ഓപ്പറേറ്റീവ് ICU. അവരുടെ ബൈസ്റ്റാൻഡേഴ്സ് അവർ വളരെ സന്തോഷത്തോടും അതിശയത്തോടുകൂടിയും പറഞ്ഞു, ഇത്ര ഫാസ്റ്റായിട്ടും ഇത്ര പ്രിസൈസായിട്ടും മറ്റേ ഡിപ്പാർട്ട്മെൻറ്റുകൾ കോർഡിനേറ്റ് ചെയ്ത് ഒരു പ്രമുഖ സെൻറ്ററിൽ നിന്ന് ഇപ്പോൾ ചെയ്യാൻ പറ്റില്ല, കാര്യം ഇമ്പോർട്ടൻ്റായിട്ട് സർജറിക്ക് എടുക്കാൻ പറ്റില്ല, 1-2 ദിവസം എടുക്കണം, അതൊക്കെ പേസ് ചെയ്ത് അടുത്തൊരു റെഫറൽ സെൻറ്ററിൽ പോയി ചെയ്യണം എന്നൊക്കെ പറഞ്ഞത് ഒരു 2 hours കൊണ്ട് നമുക്ക് പേസ് ചെയ്ത് സർജറിയും കഴിഞ്ഞ് പേഷ്യൻ്റെ പോസ്റ്റ് ഓപ്പിൽ എത്തുന്ന രീതിയിലുള്ള ഇത്ര ഒരു വളരെ ആക്റ്റീവായിട്ടുള്ള ഒരു ഹോസ്പിറ്റലും ഡിപ്പാർട്ട്മെൻറ്റുകളും ആണല്ലോ എന്ന് ഞങ്ങൾ അറിഞ്ഞില്ല എന്നവർ വളരെ സന്തോഷത്തോടു കൂടി അവർ നമ്മുടെ അടുത്ത് പറഞ്ഞു. അത്ര വളരെ ആക്റ്റീവും ഇൻട്രാക്റ്റീവും സപ്പോർട്ടീവുമാണ് ഹരി ആൻഡ് ടീം. ഐ എം എക്സ്ട്രീംലി താങ്ക്ഫുൾ ടു യു, ഹരി. ഓവർ ടു ഹരി.
Sajid sir, thank you for your kind words. As you all know, we are 3 cardiologists there. Nishant and Vijit are the other 2, and we run in synchronous. Most of us see that in other hospitals there is always a problem between either 2 consultants or 2 departments, but I am very fortunate that we have a department where all of us are in sync. If I am not there, my patient will be taken care by Dr. Nishant or Vijit, and if he is not there, I will be taking care. If somebody is having some issue, we will be cooperating. That is a very great thing in our department. So today I will be discussing mainly cases and scenarios and how we managed. It will be interesting to see how these cases come to us and how we manage these patients rather than going to some theory. So first, it is a very common thing, and most of us say that this is our bread and butter, that is an acute MI in cardiology. So this is a case, a patient who had diabetes, hypertension and dyslipidemia. He's a 60-year-old male. He came with acute onset chest pain and diaphoresis lasting for 2 hours duration. And he is residing near our hospital only. An ECG taken from our ER showed complete heart block with ST elevation in lead 2, 3 and AVF. and reciprocal ST depressions in 1 and AVL. So this is a common scenario. So how we have to manage this patient? What is the approach? So the diagnosis, there is no doubt, it is an inferior wall STEMI with a complete heart block. And primary care from ER itself, or when the patient, this type of patient comes to a peripheral hospital, our first aim is to see that the patient is hemodynamically stable, and if unstable, try to stabilize to the extent possible. So all of us know that only when you open up the artery, either with a primary angioplasty and stenting, or using a thrombolytic, the patient is going to improve. But primarily when you have a patient with hypotension, complete heart block, severe pain and all, you should give priority to immediate stabilization. So even if the patient comes to a hospital where you don't have angioplasty facility, if the blood pressure is low, we will suspect associated RV infarction also, because always inferior wall MI can be associated with the RV MI. Right ventricle is supplied by the RV branch, which is coming from the right coronary artery. So when you get a right coronary artery occlusion, you can easily have an associated RV MI, which usually presents with profound shock, and it is responsive to fluids. That is a positive thing. So if you give 1 or 2 pints of fluid fast to the patient, his BP will improve, and the RV, if you increase the preload to the RV, the afterload will also increase, and the cardiac output will be maintained. So that can be done. If you suspect that inferior wall MI coming to you in the casualty or some other hospital with bradycardia and hypotension, first of all, we can give fluid, make the patient stable, and then give antiplatelet. Studies have shown that giving antiplatelet as soon as possible reduces the mortality. And the newer drugs like ticagrelor, if you give to the patient before reaching the cath lab, there was a study which showed that the two groups, one group ticagrelor was given at the point of contact immediately, in the ambulance or when the emergency person first see the patient, and another once the patient is shifted in the cath lab just before the primary angioplasty. In these two categories, the patients who were given early, the proportion of patients having open vessel when you do an angiogram was very much higher in the patients loaded with ticagrelor. That is, when you load the ticagrelor and you shift the patient to a center, usually it takes around 30 minutes or 1 hour. We aim for a door to balloon time of less than 90 minutes, but due to some traffic and all, usually patient reaches hospital, then goes to emergency department, then ER, from there to cath lab. So there is a delay. So if you give a potent drug like a brilliant ticagrelor, these patients have opened up artery when you do the angiogram. You may not find a 100% occluded artery. You may find a 99% occluded artery with some flow antegradally, which will maintain the myocardial viability. So giving antiplatelet, stabilizing the patient, and loading with the statins is the primary thing which you have to do when you see a patient with acute STEMI or an acute MI with hemodynamic instability. Then comes the role of the cardiologist and opening up the artery and all. So we have three options: clopidogrel 600 milligram, ticagrelor 180 milligram, or prasugrel 60 milligram. So aspirin is a must. We all know we give 300 milligram of aspirin. So if the patient is going for a primary angioplasty, the dose of clopidogrel is 600 milligram, not 300 milligram. And if we are planning for a ticagrelor loading, it is 180 milligram. One tablet is 90 milligram. So you give 2 tablets of ticagrelor, 180 milligram. And if you are planning for prasugrel, then it is 60 milligram. It comes as 10 milligram tablets, and you have to give 6 tablets. But there is a downside to using prasugrel. That is why we don't usually see patients being prescribed prasugrel. Prasugrel was associated with increased CABG related bleedings and increased intracranial bleeding and major bleeding requiring blood transfusions. So the STEMI patient, we all know most of them will undergo primary angioplasty, but there can be some situation where you take the patient to the cath lab and find that you cannot do an angioplasty. There are so many lesions. There may be critical left main, heavily calcific lesions. So you may have to just do a balloon dilatation, or you can directly shift the patient to the CVTS department and do an emergency CABG. There can be situations like that. So if you preload the patient with a prasugrel, and unfortunately that patient goes for a CABG, you cannot do CABG immediately, or he will have profuse bleeding or other complications during CABG or post-operative period. So that after knowing the anatomy only, you are supposed to give prasugrel. You are sure that this patient is going for angioplasty and not for CABG, then prasugrel can be given. So that drug we can slowly avoid from our loading dose protocol, because we don't know what is the anatomy. So we can stick to clopidogrel 600 milligram if that is the available drug, or preferably if you have a ticagrelor with you, 180 milligram ticagrelor as soon as possible. Then comes rosuvastatin versus atorvastatin, which is better. So this also, studies have shown that people who are loaded with rosuvastatin and who continue to take high dose rosuvastatin, their recurrent coronary events is less, and it has also role in preventing contrast-induced nephropathy, no reflow, future heart failure. All those things are reduced with the rosuvastatin high dose rather than atorvastatin. So if you have rosuvastatin with you, try to load the patient with a high dose rosuvastatin, that is 40 mg, rather than atorvastatin. But no need to waste time. If you have only atorvastatin, you can give 80 mg atorvastatin also. So then comes what if you don't have a cath lab nearby, or if in a hospital your cath lab is not working or some technical issue. So what are the options? Whether to go for thrombolysis. Our always preferred option is primary angioplasty. So if you have to thrombolyze, all of us know we have used streptokinase. It is 1.5 million units, that is 15 lakh units diluted in normal saline, given within 30 minutes. That is the protocol with the streptokinase. It is very cheap, easily available. Only thing is some patients may develop allergic reactions, and intracranial bleeding and other major internal bleeding is one of the major concerns with the streptokinase. So, but in a life-saving situation, when you don't have a cath lab, or you are not in a position to send the patient for primary angioplasty, you have to think of thrombolysis. And if you don't have a high-end drug like tenteplase, alteplase or etiplase, streptokinase can be given. And now also we are using streptokinase in our medical college and some other peripheral hospitals also. So like a hub and spoke model, you can work. So if you have a center where primary angioplasty is available, but you cannot shift the patient to the center due to some reasons, there is a delay, you can act as a center where you can thrombolyze the patient, stabilize the patient, and then later shift the patient to the hospital and do the intervention, and later these patients can be followed up in the peripheral center. So this is an approach done in Western world, where man shortage is there and you cannot have primary angioplasty for every patient. There also they are doing this type of hub and spoke pattern. So immediately you lyse the patient and then go for a pharmaco-invasive strategy. You lyse the patient immediately with pharmacological drug and then go for an invasive strategy. So what are the other drugs that can use? That is tenecteplase. We usually use, we have 30, 35 and 40 milligram vials available. It is given as a bolus shot, very easy to administer. It is given according to the body weight, that is 0.55 milligram per kg body weight you have to give. You have to titrate the dose and use it like that. It is a rapid IV push. Only thing, it costs around 40,000 rupees for one vial. Alteplase, you have to give a bolus 15 mg followed by 30 minutes infusion of higher dose, then followed by a lower dose, another 30-minute infusion. It is little complicated. So alteplase is not the preferred drug for STEMI thrombolysis. It is usually used in stroke thrombolysis, because you have to give some drug very rapidly. You prefer IV, you prefer bolus doses rather than IV infusion. Then comes retiplase. So each box comes with 2 10-unit vials. So you have to give 1 10-unit vial, wait for half an hour and give 10 minutes and give the next 10 units. So you can space it like 10 to 15 minutes gap. You give one vial followed by another vial. So 2 doses has to be given. So that is the use of Retiplase. So our experience is mostly with Tenecteplase. We don't use Altiplase and Retiplase for STEMI thrombolysis. If possible, primary angioplasty is always better, and patient should reach a center with facility within 30 minutes, or else we can advise the patient thrombolysis. And we have to always target for a door to balloon time. D2B is door to balloon time of less than 90 minutes. So once the patient enters the hospital, that is considered as time 0. That is once he crosses the door. And once he goes through the ER, then to the cath lab, and you do the angiogram, see the block, and you wire the lesion and balloon dilate and open the vessel, that point is the end time. The door to balloon time should be less than 90 minutes. And usually they say that 30, 30, 30. You have to divide all these 3 into 30. The 30 is the primary physician or the person who sees the patient first. He has to make a diagnosis and hand over the patient to the cardiology department within 30 minutes. And the ER people and the people who stabilize the patient has to make the patient reach the cath lab within another 30 minutes, and cardiologist has to open the vessel within 30 minutes. You can conveniently divide it into 30 minutes. And the total ischemic time should be aimed to be less than 120 minutes. So this is the patient we were talking. So this is the angiogram. This is a left injection, which is essentially normal. So the long artery running down is the left anterior descending artery, and the previous view, the artery which we saw, the one coming straight is the left circumflex artery. So both of it are normal. So as we know, the patient had an inferior wall MI with a complete heart block. As expected, the right coronary artery, you can see that it is occluded just after the origin. So this type of occlusion you see in acute STEMI. There will be no flow across, and the dye will stay there. It will go into the thrombus, and it will stain and stay there. So what we immediately do is we take a one wire. You can see there is a very thin wire passing through the lesion, and it is parked in the distal vessel. Probably into the PDA or the PLV it has gone. We don't know where it has gone. And now this is the balloon dilatation. You can see there is a small balloon being dilated. Now you can see the vessel is opened up. So now this is what we intended, that is door to balloon time. So the vessel is opened. Now there is no ischemia, but you can see that there is a residual tight lesion. So you have opened up the vessel, but you can see there is a 90% lesion left there. So now we have to go for stenting. So this is the stent. So you place the distal part of the stent in a normal segment, and the proximal part also should be in the normal segment, and the deceased part should come within the stent. So both the edges of the stent should be in a normal segment. It is normal to normal. So now we have inflated the stent. After inflation, you can see the vessel is completely open, and there is no residual lesion. So this is primary angioplasty. So this we do regularly, and this is a very life-saving procedure, and it is one of the most gratifying procedures that you do, because patient is in severe pain, impending death, and only a patient who has experienced a severe chest pain related to myocardial infarction knows how severe it is, and they have the feeling that they are going to die immediately, and you do a procedure within 10 to 15 minutes, he is relieved of the pain, his blood pressure, everything settles. Once you open the artery, there itself in the monitor, you can see the ST segment coming down, everything settling down, the calm, you can experience the calm immediately after the stenting. So this is a very gratifying and life-saving procedure. This is one of the major procedures done in cardiology. So now we will have one or two different type of cases. At the end, if you have any doubt, we can discuss regarding any of these cases. So now I will go a little fast. This is a 72-year-old female who had no comorbid conditions presenting to our ER with history of syncope. Physical examination showed that her GCS is full, CNS was normal, but pulse rate was 30 and her BP was 160/70. So you can see that this ECG, there is bradycardia, no relation between P waves and Q waves. If you see in the lower strip, you can see that the P wave is beating on its own and the QRS is going on its own rhythm. There is no relation between the P and QRS. And the QRS is narrow. So we usually say that if the QRS is broad, it is an infrahisian block. It is below the His bundle, infrahisian block. And if the QRS is broader, narrower, it may be a suprahisian coming from above the bundle of His. So the escape rhythm is going through the normal conduction system like a supraventricular rhythm. That is why you are getting a narrow QRS, because it is utilizing the Purkinje fibers and the bundle of His and all the conduction systems, and it is traveling through that only. So the QRS will be like a normal QRS. So this patient is having a complete heart block with a bradycardia, and the P rate is 75 and QRS rate is 35, which is an escape rhythm, usual escape rhythm rates from AV node and his Purkinje system or lower down. These his areas have a escape rate of usually 40 or 30. So this is an ECG of complete heart block. So as a physician, when you see this type of ECG, or in the ER when you see this type of ECG, first thing that you have to rule out is there any reversible cause for this bradycardia or complete heart block? So what are the main reversible cause that you have to see? Ischemia. If the patient is, as the first patient we saw, if the patient is having an inferior wall MI, RCA is occluded, his AV node branch which arises from the RCA is completely ischemic. So if that is the reason for complete heart block, you have to relieve the ischemia. After angioplasty, within 1 or 2 days or immediately itself, his heart rate will become normal. Another things are electrolyte abnormality, mainly potassium. So if you have hyperkalemia, we have seen lot of patients, CKD hemodialysis patients or acute renal failure patients, drug-induced hyperkalemia. These patients coming with the ECG abnormality, severe bradycardia, complete heart block. So mainly you have to see potassium. So other changes of hyperkalemia like tall T waves, flattening of P waves, ST elevation. Hyperkalemia can produce a false ST elevation which will not be in a coronary artery territory like 2-3 AVF or 1 AVL V1 to V6. It will be generalized type of ST elevation. Those things are there. It will give a pointer towards the electrolyte abnormalities. Then drugs. Patient who already has a conduction system abnormality, if he is on beta blocker, calcium channel blocker like verapamil or diltiazem, or antiarrhythmics which decrease the AV conduction like amiodarone, or some patients may be having all three drugs, beta blocker plus calcium channel plus digoxin plus amiodarone, all those things may be inadvertently added or may be given for their condition. So if that is there, we can stop the drug and wait for the rhythm to stabilize. If it is not stabilizing, you don't attribute it to a drug, then you can go for pacing. Or severe metabolic acidosis. As you know, acidosis is a AV node suppressant. If the pH is very low, conduction will be low, and that can also lead to bradycardia and conduction abnormalities. So what you have to do immediately, this is a temporary pacemaker. So these are the two views. This is an AP view. You can see a lead coming from below. We take the femoral vein puncture, take the temporary lead. This is a temporary lead. Through the sheath, we take it through the IVC into the RA, and it crosses. When it crosses the vertebra, it is crossing the tricuspid valve annulus also, and from the tricuspid valve, it goes directly into the RV, and it is placed at the RV apex. So you can see the tip, there is a electrode, and we connect the temporary pacing unit outside, and this other end of the temporary pacemaker comes out through the sheath, and you connect the battery, and you have the control in your hand. You can increase the rate from 30, 40, 50, 60, and you can increase the output also. Usually we keep at 2 or 3 watt output. So you can increase the output or increase the rate, and you can control the heart rate. So this is the first step. This you do to stabilize a patient who is coming with a complete heart block and a bradycardia and hemodynamically unstable. And we wait for 24 hours or 48 hours and see whether this patient is having a reversible cause for complete heart block, drug induced or the other things. We meanwhile work up the patient with that. And if everything comes negative and the patient becomes pacemaker, a temporary pacemaker dependent, then you have to go for a permanent pacemaker. So how we do a permanent pacemaker? We usually prefer the non-dominant hand. Usually we take the left hand for left shoulder for the pacing permanent pacemaker implantation, because if you place in the right hand, the patient moves the right hand regularly, then it may cause issues in the early phase, and in the late phase also it can lead to getting crushed between the clavicle when you do some heavy exercise and all. So we prefer the non-dominant hand. So you take a venous injection and see, now you can see the cephalic vein coming and draining into the brachiocephalic and SVC, and it is directly going into the SVC and the RA. So you see the subclavian vein here, just below the clavicle. You take a shot and see, this is the first rib and this is the clavicle, and the point where the first rib and the clavicle joins, this triangular area is the area of interest where I am pointing this arrow. So we usually try to take a puncture there. So after puncturing, first we have put a wire and a sheath, and there comes the lead. This is the permanent lead. So this is a dual chamber pacemaker, that is why 2 punctures have been taken and 2 sheaths will be inserted, and through each sheath we will insert 1 lead into the RA and 1 lead into the RV. So first we fix the RV lead. So this lead has come into the RV. This is a screw-in lead. You can see that there are some screws here in the distal end. So these screws will be inside the lead, and once you get a good position in the RV, you check with it some parameters, and if the parameters are acceptable, you try to screw the lead into the RV myocardium. So this is a screwed lead. You can see some screws are already jutting out. So next is the RA lead. This U-shaped lead is the RA lead. So you keep it in the RA appendage. RA appendage lies like this. So this U-shaped lead goes into the RA appendage, and it is a tined lead. It is not a screwed lead. Most of us prefer to use a tined lead, because if you screw the RA appendage, there is a chance of perforation because it is very thinner than the RV free wall, and RA appendage is very likely to perforate also. So we usually keep a tined lead, that it has multiple spokes there, and it will catch one of the one of the communications inside the RA appendage. You have some rough area, so it will catch one of it and it will get fibrosed and it will not move. So we usually keep tined leads only in RA appendage, and this is the other end of the lead. Once it is attached to the RA appendage and the RV, the other end is attached to a battery. You can see that these two screws are into the pulse generator, and this is the lithium battery, which lasts for usually 10 to 12 years. And once you connect it and the pacemaker is working, you close the wound and the procedure is done, and patient is usually discharged in another 3 to 4 days, and the sutures are removed after 10 to 14 days. So these patients come for regular follow-up. Once in a year we check the battery life and all. And usually in our experience what we have seen is these batteries last for 10 to 12 years, and once the battery gets depleted and it is about to deplete, we replace the pulse generator only. The leads will be there and you replace the pulse generator with a new pulse generator. So this is the treatment for complete heart block requiring permanent pacemaker. This is another interesting case. We had a 65-year-old female with a history of hypertension. She had a bad road traffic accident leading to polytrauma. She had multiple long bone fractures which was treated somewhere else, and he had rib fractures, blunt injury chest, and CT done there showed an aortic dissection. There was a partial transection at the level of descending thoracic aorta. So as we know, this ascending aorta followed by arch, then comes the descending aorta. The area where the descending aorta becomes the retrosternal structure, the retroperitoneal structure, no, it goes near the spine. The arch is freely mobile and that part is fixed. So when the patient has a rapid decelerating injury, like in an RTA, there is always a chance of transection between the fixed part and the mobile part. So this patient had a classical partial transection there in the thoracic aorta, and she was awaiting a TVAR in Sri Chitra hospital. So unfortunately, this patient presented to us with acute onset dyspnea, desaturation, requiring NIV in the ER. Her BP was stable, but pulse rate was showing tachycardia. We did an emergency echo which showed a dilated RA-RV with PAH. LV was good. Immediately we suspected pulmonary embolism because the patient was bedridden with long bone fractures, which showed a submassive pulmonary thromboembolism involving both pulmonary arteries, and venous Doppler showed left extensive lower limb DVT in the limb where she had surgery. So this is a very critical situation. This patient has a life-threatening condition in the form of pulmonary embolism and DVT. The same time she has another life-threatening condition, that is partially transected aorta, which can go on to internal leakage or complete transection, and she can die at any moment. So the one treatment for one thing is heparinize, thrombolize, or give oral antithrombotics. You have to dissolve the clot. And another thing is aortic dissection, where it is partially transected and it is covered with layer of thrombus and fibrin, all those things which is holding the aorta together. And if you use these drugs, the patient, if develops an internal bleed or complete transection, she will die. So two differing things and differing treatment protocols. So what we thought that we will first prevent any further embolization into the pulmonary artery from the DVT that she is having, because you cannot thrombolize the patient, you cannot give heparin. So this is an ideal indication for an IVC filter. So patients who are having DVT pulmonary embolism and not in a position to take treatment for pulmonary embolism, or patient who has recurrent pulmonary embolism on an oral anticoagulant, or patient who has a very low RV reserve because of RV dysfunction, severe PAH related to multiple embolisms, chronic thromboembolic PAH. If they develop one more pulmonary embolism, they may die immediately. So these type of patients, we prefer to use an IVC filter which is put just below the renal vein, so that further large thrombuses are not put into the pulmonary artery. So if you prevent that, you can prevent sudden death up to some extent. But this always increases the risk of thrombosis there or lower down in the lower limb veins. So it slightly increases the chance of DVT, but it prevents a fatal pulmonary embolism. So what we have to do, we have to take a femoral vein approach. You can see that we have put a sheath inside, and here you can see two renal veins coming. If you closely observe, you can see that there are two renal veins going in the right and left side. So we locate where the renal veins are. Then you bring this IVC filter through the sheath, and you slowly unsheath the sheath, and the filter gets deployed. Now we have unsheathed and the filter has deployed. It has 16 legs. It looks like a spider. So it is in conical in shape, and if you have to retreat, you can come through the jugular vein and hold in the top part, and you can retrieve it through a sheath. That is why you have a nodule like thing in the upper part. So the lower part, it has 16 legs. So some of them will get attached to the IVC free wall, and some will act as filters. So we put filter in this patient, and fortunately she did not develop another pulmonary embolism, even though she had an extensive DVT. And we were not giving her heparin also, and she was in our hospital for nearly 10 days. And then after contacting with Srijitra and all, they took her for TVAR, and with the IVC filter she went for TVAR. And after that she came back to us, and we started her on anticoagulation once this was taken care of. And now patient is coming to our follow-up. The filter is still there, DVT has come down, and the patient is we are planning to give lifelong anticoagulation, as she had a massive pulmonary embolism and extensive DVT. So these type of patients, it is always better to give lifelong anticoagulation, because once they develop a life-threatening pulmonary embolism, only when you are planning for a surgery, you stop it for 1 or 2 days for your bleeding thing and immediately restart. So always better to give lifelong once you had a life-threatening pulmonary embolism. So this was an interesting case that how we managed in such a situation. So this is another patient. This is one of our staffs.
Dissection aorta.
It was treated with a TVAR. TVAR. And after TVAR only we started anticoagulation.
Oh.
So 10 days she was only on IVC filter. This is one of our staff's child. He was having class 2 dyspnea and some atypical chest pain, and he came to us. ECG was showing RBBB, and echo showed an ostium secundum AST, which was trending left to right, and he had mild PAH. So we decided for a AST device closure. It is elective procedure. So here also you take femoral vein approach. You can see a sheath coming from the IVC to RA. It has crossed the ASD, and now it is into the left atrium and pulmonary vein. So you can see the tip of the catheter is through the interatrial septum. It has gone to the left side and into the pulmonary vein. So once you take the sheath across, this is the crossing. So you can see after crossing, you take a device and first deploy the RA disc. So you slowly come back, so LA disc. So first you deploy the LA disc by slowly coming back from the pulmonary vein and reaching the interatrial septum. You get a feel and you deploy the LA disc, and then you slowly pull back the sheath and then deploy the RA disc also. So after deploying both the discs, you will get something like this. So the larger part and the smaller part, you can see two areas. Whenever you do a closure, the larger disc, you have two types of closure, one for ASD closure and one for PFO closure. So PFO is patent foramen ovale, which is usually shunting from right to left. So whenever the right pressure becomes higher than the left atrial pressure, like Valsalva maneuver or coughing or something, or some other diseases of the lung, which is increasing the pulmonary pressure, and the right atrial pressure goes up, the PFO, that is patent foramen ovale, shunts blood from the right to left, and ASD always shunts blood from left to right, and we don't close any ASD which is shunting in the reverse direction or when you have a severe PAH. So whichever chamber is having the, whichever is the chamber is donating, that side we will be having the larger disc. So in the ASD, when you have a left to right shunt, the larger disc will be in the LA and the smaller disc will be in the RA. And when you do a PFO closure, the larger disc will be in the RA and the smaller disc will be in the LA. So this is the last case. This is related to device implantation only. So this is basically a patient with a normal coronary artery, but echo showing severe LV dysfunction, ejection fraction of 30%. That is because of LBBB cardiomyopathy. The patient is having left bundle branch block. So this is a entity where the LV dysfunction is mainly due to the electrical abnormality and not the abnormality with muscles or other things. So the muscle is normal only because the patient's activation of the myocardium is in an altered way, in a left bundle branch pattern. That is the right getting activated early, then through the septum the left is getting activated. So that pattern, if it stays for a long duration, it can lead to LV dysfunction. So this patient's main problem was this left bundle branch block leading to LV dysfunction. So what options we have? We have cardiac resynchronization therapy for these patients. So who is eligible? Any patients with EF less than 35%, functional class 3 symptoms or class 4 on optimal medical management, and the patient should be on normal sinus rhythm and the QRS duration of more than 150 milliseconds. You have a class 1 indication for CRT. So like the pacemaker, we insert 2 leads, one into the RA and one into the RV, but there is a third lead, that is the catch here. So you have a third lead which comes from the subclavian vein and goes into the coronary sinus, and from the one we have kept in the RA appendage and one in the RV. The coronary sinus also opens into the RA. So it drains all the coronary arteries, and it is the venous system of the heart. So coronary artery supplies blood to the myocardium, and coronary veins collect it, and finally these coronary veins drain into the RA directly. So that is the coronary sinus. So you enter the coronary sinus and you go to a branch, and usually the posterolateral branch, which is usually we prefer something which is posterior and lateral, and you identify one of the good target veins and keep one lead there also, and this lead will help in activating the left ventricle from the posterior side. So now you have one lead in the right atrium, one in the right ventricle, and one in the coronary sinus, which is literally like in the LV, because it is in the posterior part of LV. So because of the left bundle branch block, the impulse used to come from the right side, and this abnormality was leading to the LV dysfunction. So cardiac resynchronization means you will activate the part of LV through the coronary sinus in such a way that both the ventricles are getting activated in a simultaneous way, or LV followed by RV, or RV followed by LV, whichever is giving a good parameter you accept, because now you have the control of LV pacing, RV pacing, and you have a pulse generator, and you can manipulate and decide when RV will pace, when LV will pace, and after how many milliseconds duration each will pace. All those things you can decide. So with this algorithm, you can design a plan so that the LV contracts in a proper way and LV function improves. Here also we take the subclavian puncture as in the pacemaker, and you have to cannulate the coronary sinus with a special catheter. So this is the special catheter going into the coronary sinus, and we are getting an injection to see where the posterolateral vein is. And now this is the coronary sinus lead. You can see that the lead is placed deep into the branch of the coronary sinus, posterolateral vein. And unlike the other pacemaker where we saw 2 leads, here you can see 3 leads being connected into the pulse generator. And you can see all the 3 leads, one in the RA appendage, one in LV, and one into the coronary sinus. So this is the cardiac resynchronization therapy. So before resynchronization, it will look like this. The LV will be dilated and the contraction is not coordinated. So in the right panel, you can see the difference. The LV is now contracting in a synchronous way. The other one left, you see it is like wavy contraction. It is not proper. It will not generate a good cardiac output. This is immediately after placing the CRT. You can see the next day itself the contraction has improved. So this is the left one is pre and the right one is post. You can see this one is taken after some time. So the LV has remodeled. It was dilated first, and after cardiac synchronization, it has remodeled. Its size has come down and function has improved. So this is one of the newer therapies for heart failure. There are other device therapies like ICD for implantable cardiac defibrillator for patients with ventricular tachycardia, resuscitated cardiac failure, or as a primary prevention strategy in patients who are having ejection fraction less than 30% and DCM. And CRT, as I told, it is given for only select patients. So if the myocardium is viable and the ECG is showing broad QRS, LBBB, normal sinus rhythm, and you have a normal coronary artery, this is an ideal patient for cardiac resynchronization. Usually around 30% of the patients are considered as non-responders in large studies. So if you do 10 CRTs, 3 of them may not respond, but the other people respond very well, and some of them are super responders, and this patient ejection fraction became normal after 6 months. So you can get a heart failure patient with class 3 dyspnea on 4 or 5 ducts becoming like normal ejection fraction. That much advantage is there for this device. So these are some of the cases that we have done, and there are so many other things that we do in cardiology, but I thought this selection of cases will be interesting and varied presentations. So if you have any doubts regarding any other cardiology things or preoperative evaluation or other thing, we can finally take up the question, I think.
Yeah, thank you. Hypertension, crisis and perioperative optimization. I invite Nishant and Vijit to the stage, and we can take it as an interactive sessions, and you can take up the questions directly. Guidelines or what is the current strategies in a brief?
I think you have hypertensive emergency and urgencies. So hypertensive urgency is when your patient is relatively stable. So he has an elevated BP. The exact cutoffs are usually not given, but it's accepted to be around more than 180, 120. So patient comes, apart from his BP, he is perfectly stable. That is hypertensive urgency. So in those cases, you can even start the patient on oral antihypertensives, and the aim of BP control is to reduce your mean arterial pressure by around 10 to 20% and control BP over a period of weeks. So it is not over a day. So preferably oral antihypertensives itself is enough, and sometimes even these patients need not be admitted. You can just observe them for a few hours and then discharge them home. The other end is hypertensive emergency, where you have some sort of end organ damage. Let's say the patient is in pulmonary edema, has stroke, retinal dissections, has aortic dissections, has renal failure, all those. So basically you have hypertension mediated organ damage. So again, different conditions have different guidelines. So example, stroke has a very specific guideline regarding how much you reduce your BP. Apart from that, in most of these conditions, what you do is you aim for a mean arterial pressure reduction of 10 to 20%. In these cases, you can start IV drugs. So in most cases, your IV drugs which are preferred are usually sodium nitroprusside. And if it's usually in heart failure, we prescribe nitroglycerin. For aortic dissection, beta blockers get the first choice. So you give IV beta blockers. So depending on which condition, you choose your IV antihypertensive of choice. So for cardiac patients, we have a higher indication for nitroglycerin. For most of the conditions, nitroprusside, and for aortic dissection, it is beta blockers. So again, aim for a 10 to 20% reduction. So in conditions like stroke, you have specific guidelines, whether it's hemorrhagic stroke or ischemic stroke. And conditions like pulmonary edema, you can actually bring down the BP very fast. So because your heart is in failure, you can bring down the BP fast. Dissection, aortic dissection, yes, again, you can bring down the BP, bring down the heart rate as soon as possible. So again, basically hypertensive urgency, oral drugs, patient is stable. Hypertensive emergency, patient is sick, requires IV medications, requires admission.
How we can pick up the dissection, threatening dissection?
So aortic dissection generally,
and from the primary center or in a basic periphery center.
Aortic dissection generally a characteristic presentation is pain, and the characteristic description is something called aortic pain. The aortic pain is different from your MI pain in that the pain is one of the most severe pains you can describe. So it starts off immediately. So for an MI pain, there is usually a crescendo type. So it starts off and then builds up. So aortic dissection pain is maximum at the onset. Okay, and it's a ripping, tearing type of pain, a very severe pain. and it spreads along with the dissection. So when you have the entire aorta dissecting, so the patient will characteristically say the pain starts here, it then spreads down my body into my lower limbs. This is the typical aortic pain, and once the dissection is complete, the pain becomes a dull aching pain. So that is your typical description of aortic pain. So it's most severe at the onset, doesn't have that crescendo, it migrates along the course of the dissection. And generally, you look for certain features. One, pain is very characteristic. And number two, if it is involving your ascending aorta, you look for pulse deficit. So you'll have BP difference between the upper limbs and lower limbs, or even between the upper limbs, depending on which artery is dissected. Again, you will have signs of vessel compromise. So you can have stroke, you can have renal shutdown, you can have can present as peripheral limb ischemia, even abdominal ischemia. So differing presentations based on which artery is occluded. So basically, you look for chest pain, you look for pulse deficit and asymmetrical character of the BP. And what we usually do is the basic investigation. What can be done from any point of view is a chest X-ray. So if it involves ascending aorta, you should get a widening of the mediastinum. So there are a lot of subtle signs, but characteristically what can be looked for is a widening of the mediastinum. And once you do that, then you can plan for a echo and probably a CT aortogram.
Yeah, before, yes.
Yeah, since he is treated with oral drugs.
Yes.
Is the ideal drug?
No, you can. It depends. Let's say a patient he's on amlodipine and a combination of chlorothalidone. He skips his antihypertensive drugs for 2 days. Now, when he presents, you can start the same drugs. So it is not that it is sufficient enough to start the patient on oral drugs, and we aim for a BP control over a period of days to weeks. So if the patient has taken his drug, it is not required. The mean arterial pressure 10 to 20% itself is sufficient. The aim is, although it describes it's an urgency, not an emergency, you have time. It is described as there is no end organ damage, but the BP values are sufficient enough to cause worry. So you can observe him for a period of few hours, start him on oral drugs, and then you can even discharge him and ask him to follow him up in the OP.
So regarding the pain management in periphery centers.
Pain management.
Chest pain.
Okay, chest pain management.
See the aortic dissection, you said severe pain.
Yes.
So regarding pain, we need to manage in the periphery center.
Yes.
Whether we need to take some oral medication or we need to go for some IV.
I think when you describe aortic dissection, I don't think you can give an oral medication. The pain is so severe, it is so dramatic. I think you would require IV medications, definitely. But the problem is, again, then diagnosis of aortic dissection, even in a tertiary care center, is very difficult. So when a patient presents with chest pain, I think the first thing which should come is actually ACS. So aortic dissection, again, is a pretty rare presentation. So whenever these are all aortic dissection comes once in a while. So I think the first priority you should give is to ACS. And once you diagnose aortic dissection, like if it is a type A aortic dissection, again, there is no point even for a cardiologist to keep it. The patient goes straight to your OT. Okay, it's not even a cardiologist domain anymore. So once it goes for a type B, that is, it's past the ascending aorta, it is there when a cardiologist actually comes in. So I think if you suspect aortic dissection, straight away refer these patients.
Yes, stabilize the BP and by the vitals,
Again,
and then you step.
So BP stabilization is a bit problematic because again, you are supposed to give high dose. The first line drug is to give, you cannot give nitroprusside or nitroglycerin straight away, because when you give a vasodilator, it is going to increase the hemodynamic stress and you will have propagation of the dissection. So your first line drug is an IV beta blocker. You can target extremely low heart rates, 45 or 50. So you reduce the shear stress. After giving IV beta blockade, when once adequate beta blockade is achieved, then you can give nitroprusside and nitroglycerin as your second line, third line use. The first drug is always IV beta blockers. And again, it is, as I said, when you have a type A aortic dissection, there is no role for medical stabilization. Medical stabilization
Sure.
would push these patients to the theater.
Exactly. Okay. It's clear. Well, my next point I want to raise is regarding the arrhythmias. Arrhythmias in a hospital setting or in a clinic. What are the problem arrhythmias? Or you have to immediately intervene or refer or whatever thing. Or what are the type of arrhythmias you can manage and there, or you can you get some time to refer or something. Or life-threatening type of arrhythmias. Of course, you're in a cardiac arrest, of course, we all know clinically it's evident. Other type of arrhythmias, how will you pick up the ECGs? ECG is the only tool available there. Of course, your clinical pulse determine checking up the pulse and all. What kind of arrhythmia you have to immediately refer, or what any kind of a medicine you have to give and then refer, or you can keep the patient there with some oral medication or IV medication.
Arrhythmias are of different types. We have bradyarrhythmias and tachyarrhythmias. First and foremost, when a patient comes to you with an arrhythmia, say for a tachyarrhythmia, see whether the patient is hemodynamically stable or not. If hemodynamically unstable, I mean, you definitely have to intervene. First, when you consider for a simple case of atrial fibrillation itself, with fast ventricular rate, with hemodynamically unstable hemodynamics, you have to give defibrillation. So, as far as possible, try to stabilize the patient at first, at your very case. Then you will refer. So, whether it is ventricular tachycardia in hemodynamically unstable presentation, you have to defibrillate. If the patient comes to you in a hemodynamically stable state, if it is case of atrial fibrillation with fast ventricular rate, you can try first a rate control strategy first. Ideally,
exactly, I want to pinpoint on the AF part. You just continue. This is the common arrhythmia what we all see routinely we all see. It's a rate controlling and how we can manage all these things. Of course, continue.
excessive ventricular tachycardia itself presents with a hemodynamically stable state. You can even try, without going for defibrillation, you can try drug therapies like it's amiodarone. It's a wonderful drug. It's commonly available in almost any setup. Then comes your bradyarrhythmias. Bradyarrhythmias, of course, high degree AV blocks. If it is an infrahisian type of blocks, it's usually it won't respond to your medications like atropine and all. And in such cases, if your setup provides a pacemaker, a temporary pacing, can be an invasive pacing or an external pacing, that will be better. Or else, in such cases, that patient has to be referred to heart center where a pacing.
AF, how we can pick up the AF and from the ECG itself? It's very basic, yes, but still.
From the ECG itself, we can pick up AF.
Okay.
There's no doubt about it.
Nishan, could you
Sir,
add?
one thing with AF.
Yeah.
See, there are two strategies: rate control and rhythm control. So when you say rhythm control, you can go for DC cardioversion or you can go for pharmacological conversion. But the thing which is important to know is there is always a thromboembolic risk. That has to be taken into consideration. So, and the risk generally occurs after you pharmacologically or DC cardiovert. Not when the patient is in AF. Generally, when the patient reverts to sinus rhythm, that is when the risk is maximum, usually on day 2 and day 3. That's why I said it is not blind. You cannot simply blindly give amiodarone or DC cardiovert these patients. There is actually only 2 emergency indications for pharmacological cardioversion. So one is for cardioversion as such. So one is when the patient is hemodynamically unstable, and 2 is when you have a pre-excited AF. So AF with WPW. So these are your only 2 conditions where you actively or you have to pharmacologically or DC cardiovert these patients without taking into consideration the thromboembolic risk. In all other cases, you have to take into consideration the risk of thromboembolism. So suppose you have a rheumatic heart disease, mitral stenosis, who is coming to you with a rate of say 180. Patient is having a BP of 120/80. So if hemodynamically stable, now blindly giving amiodarone or DC cardioverting these patients can potentially lead to a large stroke. So again, before you give amiodarone, always take into consideration the take into consideration the thromboembolic risk. So what a cardiologist does is he can do a transesophageal echo or sometimes even a cardiac CT, look for a clot, and if there is no clot, you can maybe you can convert these patients. but always take into consideration the thromboembolic risk.
Yeah, of course. In a clinical practice, most of the time we come across with a good number of patients with chronic AF, with right control stable, rate stable and all, acute hemodynamically stable and all. How frequent we have to assess this echocardiography assessment and all? These kind of chronic AF patients, or they are coming for any intervention, you have to, like any surgical intervention or something, or otherwise you have to periodically check it out.
One depends on the nature of the underlying disease. There are certain conditions where AF is poorly tolerated, but when an AF patient comes for a surgical clearance, usually these patients are on anticoagulants. So either on Novax, where you stop the anticoagulation on 24 to 48 hours prior, or on vitamin K antagonists like warfarin or acinocomarin, where you look at the INR and then decide. But again, these patients can undergo surgery provided you take into consideration the underlying structural heart disease. For example, AF in a hypertrophic obstructive cardiomyopathy is completely different from AF with concentric LVH only. So again, the underlying condition takes precedence.
Underlying condition is the important one. Second, to answer.
Fentanyl versus morphine.
Okay, I'll take that actually. So traditionally we give morphine. Morphine is considered one of the golden agents. It has been, I think if you ask our professors in 1988, they used to give 15 milligrams of morphine when an ACS patient comes. There was no SK at that time. And the patient would sleep for 2 days, and then when he awakens, he'll have no pain. Morphine is still a wonderful agent. The only question which comes in is because it has been found in studies that morphine interferes with the antiplatelet action of ticagrelol. So the absorption of ticagrelol is reduced. So that is something we don't want. So I think in those conditions, fentanyl takes over some precedence. So when you're loading the patient, when the patient is going for thrombolysis, not a problem. When you are conservatively managing an MI, so the patient presents to you late. So in those cases also not a problem, but patients who are being planned for PCI, especially emergent primary PCI, I think you can give fentanyl, and especially fentanyl is more effective also.
Yeah, any queries?
They have combined with fentanyl and morphine.
I am not aware. I think this trial was called the transition trial, but it was with morphine only, not with fentanyl. I am not aware of a trial with fentanyl.
Fentanyl and antiplatelet. Morphine versus fentanyl.
No, now we don't use morphine for acute coronary syndrome pain management. As Nishant has already pointed out, even with clopidogrel, when you are using morphine, there can be absorption problem. And now the preferred drug is fentanyl if you want to give in ACS patient. Morphine in some settings of pulmonary edema and all, we have been using morphine. You can use in that subset, but for specific ACS pain management, morphine is not the first drug of choice.
Second. Yeah, yes, sir. Please, sir.
Because in the periphery, what's the periphery when you are coming to an ACS, loading those suppose you can give. What's the analysis?
Fentanyl can be given, sir. Fentanyl can be safely given.
Available there. It's not available in any. Is it available in any? It's not available in any government institution.
If blood pressure is there, we can give sorbitrate. Otherwise, morphine and fentanyl only relieves the pain, such a severe pain.
For ACS pain management, the unfortunate fact is that nothing is available in the
Opioid type of drugs only will reduce this much pain. Otherwise, we cannot.
We need opioids, but unfortunately, sir, is rightly said. All the times, I don't know correct. When nowadays, what is, and all the times we get diazepam, sorbitrate, aspirin, and then refer the patient.
Fourth win.
Any tramadol or like medicines has any role? That's what these are the
Tramadol
drugs which is available. At least that available in the. Yeah.
Tramadol we are not using.
It's not recommended actually.
It is not.
It's not a good strong. It's not a strong opiate, and it's not recommended.
No, you can try it. There is no contraindication for giving tramadol, but only this opioid type of analgesic will work in this visceral pain. Cardiac pain is a deep-seated visceral pain.
Yes, any questions we can take? We will, sure, I am guaranteed that we will wind up in 5 minutes. Okay, we can take some more questions. Arjun, anything? And on thing, since we have a good number of surgeons and anesthetists are there, and regarding just a patient is on anticoagulants. Yeah, please, Suresh.
Yeah, you already covered that. Actually, aspirin you have to definitely give 300 milligram of aspirin, and clopidogrel only if you are having, you can give 600 milligram of clopidogrel. If the yes, you can safely give 600 milligram when the patient is having ST elevation MI and you are planning him to shift for a primary angioplasty. 600 milligram should be given because 300 milligram it will take at least 6 hours for the drug to act. So when you give 600 milligram, the time to action is lesser. So it becomes active within 2 hours or 2.5 hours. So you can give 600 milligram if you are referring him for a primary angioplasty or for an angioplasty. If you have ticagrelor with you, always good to give ticagrelor when you are referring for primary angioplasty. Prasugrel is a drug that you don't advise to give beforehand when you don't know the anatomy and you have not decided whether it is angioplasty or CABG. So clopidogrel, if it is available, you give 600 and aspirin 300, that is standard. If available, ticagrelor can be given. Statin, either atorvastatin 80 or preferably if you have rosuvastatin 40. No. Either clopidogrel or ticagrelor, only one. Aspirin is there. If you have ticagrelor, that is the best one. If you don't have that, clopidogrel 600 milligram. Plus rosuvastatin preferably. Sorbitrate, if you have a good blood pressure and patient is having severe angina, you can give sorbitrate. But borderline blood pressure, better to avoid that, and especially in RCA infarct and inferior, you are suspecting in RVMI borderline blood pressure, don't give nitrate.
Door to balloon time. Is it related to the patient coming to the casualty?
Yes, patient once enters the hospital door, that is the door, and balloon is the ballooning time.
Local peripheral hospital.
Ideally, if the peripheral hospital, you can shift the patient to a center where primary angioplasty is done within 30 minutes, and they can do the procedure within another 90 minutes. That is the total ischemia time of around 120 minutes. If you can achieve that, you refer the patient for primary angioplasty. If the center is already 2 hours, 3 hours away, you cannot refer, and the patient will not reach there within 30 minutes. You can always thrombolize. It is a good option. You can thrombolize and then refer the patient. So now what we see in our setup is because of the medico-legal issues and thrombolizing without a cardiology support, if the patient develops bleeding or some arrhythmia after thrombolysis, that concern is there in smaller hospitals, and they don't usually thrombolize and they refer. Thrombolysis, if the patient you cannot refer to a center, you thrombolize immediately. The needle, this a door to needle time is also there. No, if you are having lytic with you and you are planning to thrombolize, you can thrombolize immediately. If you take it, you see that patient, you cannot refer the patient to a center before 30 minutes. You can thrombolize then and there itself. Thrombolize itself is not available, and if you are referring the patient, better to refer to a center where primary angioplasty is done. If that is also not there, then you can. Total ischemia time should be less than 120 minutes. That should be our aim. No, angioplasty, we are doing angioplasty after 6 hours, 8 hours, 10 hours also. But the benefit may not be there. If you refer early and the patient gets a good result, his LV will be normal and you will preserve the muscle. It is called time. You usually say that just time is muscle. Each minute lost, you are losing valuable muscles and patient will land up in LV dysfunction. We have done after 24 hours also. When a patient will be having chest pain, continuous pain, ECG showing ST elevation, when you ask the history, he will be telling that I am having this pain from yesterday. He will be coming to your OPD after one day. Index pain is 24 hours, but you go on doing because the patient is still having pain. there is some viable myocardium. So you do with the intention of saving whatever muscle you can save.
Yeah, on sir, please.
The door to wire crossing or door to balloon time indicates the efficiency of your system. So the ideal time is if a patient presents to you with STEMI to a primary health center, you're supposed to take an ECG and diagnose STEMI within 10 minutes. So 10 minutes is your diagnosing time. So if this patient presents to a if you want to thrombolyze the patient, the door to needle time is 30 minutes. If you want to do a primary PCI for this patient, it's 90 minutes. If you want to refer this patient, he should reach the distance should be and if the patient comes to let's say a peripheral center, and if he estimates that the time to reach the primary PCI center is more than 120 minutes, he can thrombolyze. If it's less than 120, he should refer it.
Yeah,
That
it's
is how
clear. It's clear. Thank you. And I will come to that last question to Vijit, and I invite our MD, Dr. Prem Kiran, to propose the vote of thanks. Before that, since our perioperative setting just prior to the surgery, mainly two concerns, mainly the anticoagulants, which one to continue and which one to hold on likewise. What is the current guideline? And second point is the beta blockers. What are the beta blockers you can continue or this thing?
Antiplatelet.
Antiplatelets.
So patient.
Say surgical patient.
So a known case of ischemic heart disease patient, a CAD patient, planned for a surgery. A patient might be on ecosprin or a dual antiplatelets. So when to stop, or can these drugs can they be stopped? That's the question. So all depends on the individual characterization. If the patient has undergone a PCI with stents, single stent or multiple stent, and also based on the size of the stent, and all these factors come into consideration. So if the patient had a PCI and they had a DES, the targeted stent in situ. So this patient at least 6 months, now the guidelines say at least 6 months they should continue dual antiplatelet therapy. So before that, we would avoid surgeries as far as possible. So after 6 months,
all elective surgeries should be avoided within the 6 months of period. The patient is on dual antiplatelet.
Yes, DES, and patient on DES.
Yeah.
So in such cases, so after 6 months, the guideline has told you may stop both the drugs, but it will be preferably to stop one drug, and that too also weighing the benefit risk ratio of bleeding and thrombus. The next is about bare metal stents. So in bare metal stents, you can stop the drugs. You should continue the drugs for at least 1 month. So after 1 month, you can stop.
Okay.
And do the surgery.
Rather than that 6 months in the drug-eluting and other type of stents, and the bare metal, you can take in 1 month.
Take on one. And another thing is POBA, plain old balloon angioplasty. That means the procedure done is just balloon dilatation. There is no stent in situ. In such cases, you can do the surgery even before that, like 2 weeks.
2 weeks.
2 weeks. After 2 weeks, you can do this. You can stop the drugs and continue surgery.
Okay.
For CABG and all, you should wait at least 3 months.
And
After 3 months,
regarding the clopidogrel, what's the current?
it's better to stop clopidogrel before surgery because bleeding risk is more. For
How
and
much
continue
duration wise? How
clopidogrel, it's 7 days.
7 days.
And the ecosprin is 5 days.
Sure. The beta blocker also.
Beta blockers, it's always, beta blockers is known to reduce the perioperative mortality. So patient on beta blockers, it's better to continue the beta blockers without.
On the day of the surgery, which one have to block? I mean,
No. If the patient is patient on beta blockers, it's always better to continue the beta blockers during the surgery itself. Because it
all
is
kind
not
of beta blocker or selective one or non-selective, that kind of
any beta blockers, anything. If the
Even
patient
you
is
can give it on the day of surgery. If it in the morning, you can give it.
Yes. If the patient is not on any beta blocker, such a patient comes, you should assess the risk. So the patient, you say the MACE risk, major adverse cardiac event. The patient, for the probability of the patient that can develop MACE. So if the probability is high, such patient is always better to start a beta blocker. But that should not be not on the day of surgery. It should be started even at least 1 day prior.
Okay.
Because sometimes when you start straight away, it's very known to produce.
If you are starting, you have to start it
at least
prior
1
to
day
1 day prior
at
to
least
surgery,
1
not
day
on the
prior.
same day.
Not on the same day, because
Okay.
it's known to produce
It's
some
done.
cases hypotension.
On last single question is that when the post-operatively patient is having a raised BP, it's not not on any medication and all. I mean, which drug we have to, Nishan, we can start with depending on like a diabetic or any other comorbidities you can.
I think long-term BP, if the not a known hypertensive,
Not on medication, we don't know which is not hypertensive or not.
If the patient is not a known hypertensive, doesn't have features suggestive of long-standing hypertension, post-op BP, I think you should look at other features like pain relief, full bladder, excessive IV fluids, all those things. If the patient doesn't have all these things and the patient is still having, say, an elevated BP, let's say around 160, 110, even at that, a borderline elevation of BP is pretty much accepted. But the problem is if it's too high, you can maybe start oral agents depending on it.
Which agent we can start with?
I think that will be an individual preference. I usually start with calcium channel blockers.
Amlodipine.
Amlodipine.
Start with 5 milligram amlodipine.
I usually start with amlodipine.
Sure. Good. Thank you. Yeah. Right. Oh yeah, sure.
It actually, CRT is right.
CRP.
CRT volume is increasing, but what is happening is last 1 or 2 years there is another modality called left bundle branch pacing. So here you directly pace the left bundle rather than going through the coronary sinus and indirectly pacing the LV. You go and directly pace the left bundle. There are some selected patients only you can do. If there are disease in those segment, you cannot do. So that is coming up, and because CRT is decreasing, because CRT cost is 3 to 3.5 lakhs for that device. But this left bundle branch pacing can be done like a normal pacemaker with even 1.5 to 1.75 lakhs you can do. It has become half the price. So that factor is there, and CRT volumes are slightly coming down, and left bundle pacing are moving up.
Sir, please, sir.
You are mentioning about hyperkalemia. One problem that we are facing is where there are no facilities for electrolytes monitoring. People start hydrochloric acid or chlorphenidone, and patient continues to take. So, what's the sort of direction for that? Like somebody starts advice or patient goes on taking that without ever monitoring electrolytes and finally ends up with electrolyte imbalance and comes to hospital. Any guideline on that?
Usually, when you start an AC inhibitor or ARB, you have the risk of hyperkalemia. And when you have this diuretic is initiated, you have hyponatremia is the usual one, and some potent diuretic can cause severe hypokalemia also. So this combination of telmisartan with the diuretic can lead to hypokalemia, and telmisartan will tend to increase potassium, and this will take care. So usual problem what we see in this combination is hyponatremia. So what I advise is patients who are on AC inhibitor or ARB or any diuretic, I ask them to check the electrolytes after 2 weeks of initiation. If there is some abnormality, potassium is going up and all, I will reduce the dose of AC or ARB. And if the patient is developing hyponatremia also, I will stop the diuretic or reduce the dose of diuretic. This is the acute phase. And if the patient is tolerating this drug for 1 or 2 months and there is no hyperkalemia or something, usually it will not occur unless there is another precipitating factor like an NSAID use, increased potassium in diet, or renal failure, or something should be there to precipitate if it is not there in the first 1 or 2 months. So a patient has other sources of sodium loss or potassium loss, this can activate that. So if a patient on chronic stable dose of a diuretic or an AC inhibitor, if its values are normal, then there is no need to regularly check every month or 2 months. But there is a fever or infection or an antibiotic therapy or something is there, some diarrhea, vomiting, something has happened, then you have to definitely check.
For AS and ARB, the guideline is check on day 3, 7, 21 and 90 days. once in every 3 months after that. So 3 days, 7 days, 21 days, and every 90 days. For diuretic, I'm not think such a guideline is available.
Okay, thank you. If you discussing, we can keep on discussing all these things. And with all the discussions, it's very clear that these are all our 3 cardiologists are there very expert and in their field, and clinically also they are very expert, very efficient also. Our humble request is make utilize their potential in full strength. And all of you, all my dear friends, I apologize you for the late kickoff. And to conclude the session, I invite Dr. Prem Kiran for the official.
Good evening all. So, ഒരു ഒഫീഷ്യൽ വോട്ട് ഓഫ് താങ്ക്സ് ഉണ്ടെന്ന് തോന്നുന്നില്ല, എല്ലാം നമ്മുടെ ഓൺ ഫാമിലി മെമ്പേഴ്സാണ്. സോ ഫസ്റ്റ് ഓഫ് ഓൾ ലെറ്റ് മീ താങ്ക് അവർ വണ്ടർഫുൾ കാർഡിയോളജി ടീം ഫോർ ദിസ് ഗുഡ് പ്രസൻറ്റേഷൻ. അവർ നല്ല പ്രെപ്ഡപ്പായിട്ട് ഇതായിട്ട് വന്നതായിരുന്നു. നമുക്ക് കുറച്ച് ടൈം ഷോർട്ടേജ് കാരണം കുറച്ച് കട്ട് ഷോർട്ട് ചെയ്യേണ്ടി വന്നു. ബട്ട് എഗെയിൻ വൺ മോർ തിങ്, ഇപ്പം മോഹനൻ സാർ എൻ്റെ അടുത്ത് പറയുമായിരുന്നു, നമ്മൾ ആക്ച്വലി ഈ ടാർഗറ്റ് ഈ ഒരു പരിപാടി നടത്താൻ തന്നെ പ്ലാൻ ചെയ്തത് നമ്മുടെ കാർഡിയോളജി ഡിപ്പാർട്ട്മെൻറ്റ് എന്തുമാത്രം സ്ട്രോങ് ആണ്, എന്തുമാത്രം നല്ല രീതിയിൽ ഓരോ കാര്യങ്ങൾ ചെയ്യുന്നുണ്ട് എന്ന് ശരിക്കും പുറത്തോട്ട് എന്ന് ആദ്യം പറയണമെങ്കിൽ ആ ഡിപ്പാർട്ട്മെൻറ്റ് പുറത്തോട്ട് എന്നെ കൂടുതൽ അറിഞ്ഞോടായിരുന്നു. അത് അറിയിക്കുക എന്നുള്ളതാണ്. അറ്റ്ലീസ്റ്റ് നമുക്ക് നമ്മുടെ ഹോസ്പിറ്റലിൻ്റെ അകത്ത് ഇൻറ്റേർണലി നമ്മളത് അറിയിക്കുന്നു, ഇനി അടുത്ത് പുറത്തോട്ടും സ്പ്രെഡ് ചെയ്യണം. ഇപ്പം സുരേഷ് സാർ നമ്മുടെ ഇൻവൈറ്റ് പ്രമാണിച്ച് വന്നായിരുന്നു, ഡോക്ടർ ജിതിൻ സാറും വന്നിട്ടുണ്ടായിരുന്നു, ഹൂസ് ഓൾറെഡി സപ്പോർട്ടിങ് അസ് എ ലോട്ട്. അവരുടെ പേഷ്യൻസിന് ഒരു കാർഡിയോളജി ഒരു കൺസൾട്ടേഷനോ അല്ലെങ്കിൽ ഒരു സർജിക്കൽ സൈഡോ സ്പെഷ്യാലിറ്റി കൺസൾട്ടേഷൻ വേണമെങ്കിൽ അവർ ഓൾറെഡി നമ്മളുമായിട്ട് സഹകരിക്കുന്ന ഡോക്ടേഴ്സാണ്. അപ്പോൾ അവർ വന്നാൽ അവരുടെ ഞാൻ നന്ദി പറയുന്നു. ആൻഡ് ഈ ഒരു മെസ്സേജ് നമുക്ക് കുറച്ചും കൂടെ സ്പ്രെഡ് ചെയ്യാൻ പറ്റട്ടെ. നമ്മൾ അടുത്ത വീക്ക് ഫ്രൈഡേ വേൾഡ് ഹാർട്ട് ഡേ ആണ്. അപ്പം വേൾഡ് ഹാർട്ട് ഡേ എന്നുള്ളൊരു അനുബന്ധിച്ച് നമ്മുടെ കാർഡിയോളജി ഡിപ്പാർട്ട്മെൻറ്റ് കുറച്ച് ആക്ടിവിറ്റീസ് വിൽ ബി കണ്ടിന്യൂയിങ് ഫോർ നെക്സ്റ്റ് 1 month. സോ അതിൻ്റെ സ്റ്റാർട്ടായിട്ട് നമുക്ക് ഈ ഒരു പരിപാടി നടത്തിയത്. അപ്പോൾ അതിന് വന്ന എല്ലാവർക്കും താങ്ക്സ്, നന്ദി. എനിക്ക് ഓൾറെഡി ലേറ്റ് ആയതുകൊണ്ട് ഇനിയിപ്പോൾ നമുക്ക് എല്ലാവർക്കും ഡിന്നറിലോട്ട് മൂവ് ചെയ്യാം. താങ്ക്സ് എവരി വൺ.